we really decided that not only did we need to expand for survival in the market, but we also needed to diversify our service offerings. And that's where the staff and our volunteers came up with MiraSol Health.
How does the identity of MiraSol better reflect the needs of families today?
We live in a very beautiful area, so many people are moving here, specifically individuals over the age of 65. And so with that comes, dynamic healthcare conditions. So
How do you translate the philosophy of that into a culture that shows up for the patients during these hardest moments?
So any chance I get to participate, I love to show up because we can always put a lesson with that.
Is burnout an issue in hospice area, and is it something that you have to manage?
What I like to say that we're combating is nursing fatigue. They are working so hard that they need to take a break. And so what we do is we really...
Hello there, and welcome back to Healthcare Journeys. I am your host, Kevin Rosenquist. Thanks for joining me today.
This podcast is brought to you by S2M Health, a trusted partner for U.S. healthcare payers and providers. From accurate risk adjustment coding to full spectrum RCM services, S2M Health combines clinical expertise with precision operations to drive better outcomes across the healthcare ecosystem.
Caring for people at the end of life is one of the most emotionally complex parts of healthcare. It requires compassion, clarity, and a level of trust that most other care settings never have to navigate. And yet, the nonprofit organizations providing that care are facing unprecedented operational pressures, staffing shortages, rising costs, and tougher reimbursement environments than ever before. My guest today is James Dismond, CEO of MiraSol Health, a nonprofit serious illness organization serving the Lowcountry for over 40 years. MiraSol includes hospice care, community-based palliative care, grief counseling, behavioral health support, and volunteer services. Under James's leadership, the organization has dramatically expanded its reach, restructuring operations for growth, and rebranded from Hospice Care of the Lowcountry to MiraSol Health to reflect a broader mission. James, welcome. Great to see you.
Super excited to be here. Thanks for having me.
Yeah, absolutely. Your evolution, your company, MiraSol's evolution from hospice care of the Lowcountry into a full continuum of serious illness and grief support is quite a shift. What drove that decision to expand the mission, and how does the identity of MiraSol better reflect the needs of families today?
Yeah, great question. Really, two things drove the direction that we are continually heading towards. And that's one, our community was diversely changing and expanding. We live in a very beautiful area, so many people are moving here, specifically individuals over the age of 65. And so with that comes, dynamic healthcare conditions. So we needed to evolve to serve our community in a greater capacity. And so with that, we realized that hospice was a dynamic barrier, the word itself, and that many families were afraid of the word hospice. It had a negative connotation attached to it, even though we tried to spin it into more of a positive framework. And so after interviewing our nurses, the community, we really decided that not only did we need to expand for survival in the market, but we also needed to diversify our service offerings. And that's where the staff and our volunteers came up with MiraSol Health. And MiraSol means rare and radiant sunflower, which is a part of our brand identity.
I like that. That's cool. That's cool. And you've grown. You've expanded service areas, launched new programs, as we just talked about, but ultimately the impact is going to be emotional, relational. How do you balance the operational performance with the deeply human outcomes of these situations?
It can be extremely difficult on days. In my first 90 days as chief executive officer, I went through my own journey with hospice care services.
Yeah.
And I just spoke at an event last night about that very journey and how it truly changed my capacity as a leader, but the direction that I lead in. And so I like to say that I went from the business side of the bed to the other side of the bed which is the side where you get to hold your loved one's hand as they experience their end of life journey, and you get to be the role that you're supposed to be. So in my case, I was a son of hospice, and I got to be the son of hospice rather than being the navigator and the caretaker and all these other roles that some people have to play when they don't have supportive services. And so when we're communicating to our staff on the emotional heavy days, we ask them to take a step back and realize that, they are the support for the family, and that although we feel the emotional strain some days, what we're doing is truly beautiful. And I would say, even though it might be a cliche, most of our team, 90 to 95% of our team, are not here because of pay or anything like that. They're here because it truly is a mission that they want to fulfill and a purpose in their life.
I believe that, because there's other jobs in nursing you can get. I've always thought that hospice nurses are the true angels. I mean to take on that kind of a burden, even the most hardened, professional is gonna have those moments where it's just really just tugs at your heart.
Yeah, there's days and during onboarding, in my first week with this organization, I determined that death was my biggest fear. And so 72 hours in, I was like, ooh, I'm going to have to quit. This is
Wow,
not for
yeah.
me.
Yeah.
And luckily, we had a phenomenal CEO at the time that said, give me some time to just help me teach you about death. And this staff has truly transformed my outlook, because now what was my greatest fear is now my greatest passion. And the more we can educate on death and dying, the more I think it's less fearful for individuals. Because the truth of the matter is that every single person listening, you and I, every single person in the globe is closer to death today than they were yesterday.
Mm-hmm. Yeah. Yeah. If you can get the perspective, I suppose you have to have that sort of, that perspective in order to do what you guys do, and not just cry all the time.
Yeah, and we say that too. Like, we cry together, we laugh together. You will see all the emotions with our team, and that's what I think makes it, just so different from other places. We have a lot of people on our team that I like to call our recovering corporate employees. And they will tell you that the just sense of belonging and purpose here is far greater and far different. And that's something that we protect and value very much.
You've said that leadership isn't about standing above the culture, but standing in it. And you literally went to a team event dressed as an ostrich, I believe, to prove a point. How do you translate the philosophy of that into a culture that shows up for the patients during these hardest moments?
Yeah, to me, I've been in many different organizations, not as a leader, but as an employee. And some of the best leaders that I ever had were leaders that showed up and they participated. They walked the walk, they talked the talk. I just didn't see them in an office. And so any chance I get to participate, I love to show up, because we can always put a lesson with that. And so we've talked about the emotional heaviness of this business. And so anytime that I can be quirky or happy or, put a smile on someone's face, I'm going to do that. Even if it means putting on, a ton of feathers as an ostrich and coming in. That's just a fall party that we do to help with participation and culture. And so if I participate, I know that the majority of the organization will as well. And then we translate that into showing up for our patients when they need it, showing up for our families when they need it, and giving them the time and the space to experience whatever they're experiencing, because showing up is literally half the battle.
That's true. That is a really good point. And do you find that it's difficult to create an environment that where the compassion needed, doesn't clash with the accountability of doing the job that you have to do?
It definitely can. And so we have coined this term called compassion and accountability. And what that means is that we have space for compassion, but we have a larger space for accountability, and they should collide together, and they should work in unison together. And what that means is that we all have jobs to do, but we have compassion that this area is super heavy. But if we're walking in compassion and we're delivering care and compassion, we will be doing everything that we needed to be doing to be accountable. And what's more important about those two terms is that when someone is not doing what they're doing, what they should be doing, or they're not performing conforming to the standard that we set as our quality levels, then we start every single one of those conversations like this. Hey, I just want to let you know today is going to be a compassion and accountability conversation. And by the end of this conversation, we're going to be on the same page with a plan to get you to where you need to be. So I just want to frame that so we know that we're on the same page and that this might be a difficult conversation, but it's going to help both you and I.
Wow, that's very direct. Yeah, I mean, obviously, especially since the pandemic, nurse burnout, doctor burnout, people anywhere, everyone in the healthcare industry burnout is a big deal anyway. You know, my sister's an ER nurse, and she gets burned out too. You know, it's hard work what you guys all do. Is burnout an issue in hospice, the hospice area, and is it something that you have to manage?
Yeah, and I don't love the word burnout because I think it puts negative connotation to some really strong professionals, specifically nurses. And I don't think they're burning out. I think they might not be in the right fit, or they're so devoted to their organization that there's not really good boundaries or processes set in place to protect them. And so what I like to say that we're combating is nursing fatigue. They are
Okay.
working so hard that they need to take a break. And so what we do is we really try to provide or to understand and realize some of those warning signs for nursing fatigue. So we have mental health days built in that we will give any one of our staff members. And so if they need it, but we also reserve the right to give someone one of those mental health days if we see some of those warning signs. So my team knows that if I'm seeing those signs, I could walk right into your office and be like, I really need you to go home today. I know you might have, task heavy, and those tasks are going to be there when you get back, but this team's got your back. So why don't you just go home and take the rest of the day, or take the Friday and Monday and get 5 days off? This team has got your back. And then being a death and dying organization, when one of our employees or their family members is going through a death themselves, we don't do the standard 1 day or 2 day. We do 3 to 5 days of bereavement, and that's for any person or pet within your family, not just your immediate family.
Okay, that's really cool. Yeah, I mean, I like the way you frame that, not burnout, because you're right. I mean, it really is. There are different aspects to it where it doesn't necessarily mean that you're, I don't know, because burnout does sound like you're just done, like you're just over it, and that's not a lot of times what people are feeling. It's more like you said, the fatigue that goes along with the everyday tasks and the heaviness of what you guys do.
Yeah, and I think that employers really have to understand that if you do have employees leaving, specifically nurses, and maybe they're leaving the profession, that's where that compassion and accountability comes in, and we have to turn those binoculars inward and figure out how we can be better at retaining nurses, and that some of our policies and procedures and staffing ratios and patient ratios probably are playing into that.
Mm-hmm. You also helped launch something called the Southern Care Collaborative, a community-based hospices pooling technology, training, and compliance systems. For those who are listening who might not know about this model, can you talk about what this collaboration looks like on the ground?
Yeah, so actually inherited it. The organization was a founding member of the Southern Care Collaborative, which we're really proud of. And so essentially, it was a group of nonprofit hospices coming together and saying we could be stronger together if we're all on the same page and advancing in the right direction. We're all still independent, nonprofit, hospice and palliative care organizations, but we're working together to better serve the community. And we're trying to figure out how to share resources and how to better serve patients at a higher quality. And so we're super happy because we started with 5 founding members, and now we're upwards of 10 members, serving more than 45,000 lives throughout the Southeast, which is going to be really powerful as we start to position ourselves for the future to really be the leading collaborative in the Southeast for end of life, serious illness, and some of those disease specific conditions that people are dealing with.
Mm-hmm. Healthcare is kind of notoriously competitive, even in the nonprofit world. What do you see that tells you that the future of community-based hospice lies in collaboration than trying to outcompete your neighboring organizations, your competition, if you will?
Yeah, I think I don't think I know over the past 10 years, the hospice and palliative space has really been redefined. We used to be 80 to 85% nonprofit organizations serving the community, and that has since flopped. And so now it's about 80 to 85% on any given statistic for profit entities, with the nonprofit space drastically decreasing each year. And so, not to say that for-profits do not provide great care.
Sure.
I think it really puts more weight on the patient and the patient family member to really search for quality care and to do their research. And unfortunately, many of us just don't do that.
Right.
Whoever our physician or someone recommends, that's where we go. And so for nonprofit hospice and palliative care organizations specifically to stay afloat and to survive, collaboration is going to be key. Also, as our population ages, and over the next 5 years, it's going to boom in 65 plus year olds with chronic conditions. We're going to need to share resources because, as you can see, in 2026, federal funding has drastically been reduced. Payment reform is reducing reimbursement back to providers across the healthcare care continuum. And so we're going to have less funds, but a higher demand. So in order to care for these patients the way that they should be cared for with quality care, collaboration is going to be the only way to make that possible.
You wrote in Forbes about the coverage and access gaps in end-of-life care. Where do you see the biggest inequities today, and what practical steps can nonprofit providers take to close those gaps?
Yeah, I wish I had all the answers, because then I'd write a book or something, right?
Yeah. Well, you might be able to before too long.
Yeah, let's hope. But, I don't think it's going to be surprising to anyone on some of the gaps that I bring forth, but regulation and payment reform is really creating larger gaps for patient access and patient care. So in hospice, it's a very heavily regulated industry. And so technically someone could be struggling with a chronic illness, but not qualify for end of life support. So they would have to go into, their primary care or their specialist. And unfortunately, that isn't always the best case for them. Most people love to have or prefer to have their care at home. There's less appointments, there's less care coordination, there's better comfort. And so where I see a large gap is for medical services, specifically for people over the age of 65, needing to be provided in a facility. I think there's a time and place for that, but I think the United States of America really needs to understand that we could care for people better in their home and understand exactly what's happening. When you see someone's home, you can see the entire dynamic of what's happening rather than in a facility. So I think if we could really compromise top quality home care services with specialists and facility services, we could really see an improvement in quality outcome. And the separation between palliative care and hospice care, if we could just bring those two together so that people could receive palliative care, chronic symptom management and condition services with end-of-life coordination, because it's at some point, all palliative care patients will transition into an end of life. We could just see a better continuity of care overall, and providers would be able to do so much more.
Interesting. Okay. You've also led DEI outreach projects and worked across homelessness services, youth programs, now serious illness care. What patterns do you see in who gets access to hospice and palliative care and who doesn't?
Yeah, I'm probably not going to have the favorite answer, but I'd rather speak what I really believe is true. And, we live in a country where access to healthcare can be driven by how much money you have in your pocket or whether you're insured or not insured. And so over the span of my career, and I can say I've been the person who has put on muck boots and walked a riverbank to provide homeless services to individuals, meeting them where they are, to working in a state-of-the-art facility that is, multi-million-dollar machines. And it seems like the access issue is always the same. How close the facility is, if they have insurance, if they don't have insurance, and education level for that individual to be able to navigate a really complex healthcare system in general. And so I really do believe that that is still where we're at. And then there's a cultural divide too. We have to really understand that over the history of the United States of America, there's been many populations that have been mistreated, and some of that mistrust is still woven into those generational cultures. And so
Absolutely.
we need to try harder to disseminate that mistrust and really turn it into encouragement to access the services that they need and to meet people where they are.
Do you find that there's a lot of misconceptions or misunderstandings about hospice and what it entails?
Yeah, I think we naturally all create misconceptions on things that we're fearful about, right? The
Great way to
brain,
put it.
yeah, the brain kind of does that itself sometimes. But then there's the way we access information now can be a huge advantage, but also a huge disadvantage. I love TikTok, but just because someone's saying something on there does not mean that it's true, right? And so
that is a fact.
so when I hear people, a common misconception is, hospices give individuals morphine and then they die. And that's just not the truth. Or the misconception that you're on hospice for 3 to 5 days. Not the truth. We've had patients that have been on service for upwards to 3 years because it's just been a slow decline process. But it's been a really good quality healthcare service that they've been able to access to guide them through that journey. And so I think those are two of the common misconceptions. We do use morphine, but we do not use it in a way that would cause you to die. It's merely there for comfort measures. And the average patient with MiraSol Health is on service 80 to 90 days in our hospice program. But nationally, the statistic is for people who access hospice care, they live 29 days longer than if they did not access hospice care. And I don't know about you, but 29 more days would be significant for me.
I agree. You talked about your history. You talked about the homelessness services, fundraising. Now you're in hospice leadership. What experience outside of the healthcare world, if you will, has most shaped how you lead within healthcare?
Oh gosh, so many experiences. And as a young kid, this is going to be funny probably, but I can remember going to a chamber community event, and I saw a young man at probably 21 to 22 years old stand up and get a community leader award for just donating his time back. I think he had created some type of committee in our county that helped clean up parks or something like that. And I was like, wow, the entire room just stood for someone who was just being a good person. And I can remember way back when saying, I want to get one of those awards one day. But what I was actually probably forecasting is that what I would learn later on in life is that I really just love helping people. And that's kind of my purpose. And so I would say exposure for me to things like the chamber and seeing other people do really, really well has really foreshadowed where I needed to go. Because I can also remember being that kid, 10 to 15 years old and not being able to see past Friday night. And Friday was the most important thing in your life. And I can also remember not being able to see past 21. And then I turned 21 and I couldn't see past 25. And so I can't imagine where I would be if I really created a path for success early on in life.
We talked before we hit record about a pretty big fundraiser gala that you had last night, I believe. We're recording this on November 20th. Can you talk about that event and how it went?
Yeah, I'm still in utter shock.
Awesome.
We had a fundraiser that we've had a few times. We didn't have it last year, but we brought in a musical group and we bring in some of our top supporters. It was around 200 individuals. We do the typical silent auction raffle and what we call a paddle raise, what some people call fund in need. And we thought we had a long shot goal of $150,000, and believe it or not, we brought in a whopping $224,000 last night.
That's
with just
phenomenal.
200 people in the audience. And I mean, I was just seeing the numbers go up, and at the end of the night, I was just in tears at how much the community really truly supports this organization and sees what we're doing every single day.
Obviously they believe in what you're doing, and that's really cool that they can show it in that way and prove to you that all your efforts and your team's efforts are worth it.
Absolutely. It
Yeah.
was a blessing for sure.
Yeah. As we close out today, for other nonprofit and community-based healthcare leaders who might be listening, what's the one thing that you believe they should be thinking about now to meet this moment that we're entering?
Yes, I would say over the past 2 years, I've really been challenged because our community is constantly changing. And sometimes as nonprofits, we don't really want to change, right? We stay stuck in our core services. But the truth of the matter is, businesses that don't change really don't wind up making it all the way in the future. So they become extinct because they were unwilling to change. And the difficulty with that for nonprofits is that many times when we're applying for funding or we're trying to get people to support us, they will call that mission drift. When the truth of the matter is, we should be focused on mission expansion, because we should be growing with our communities and growing in capacity for survival and to just be relevant. And so I would encourage all nonprofit, especially community-based nonprofit leaders, to be really looking at how they can change with their community, expand with their community, because size and growth and capacity are key to survival in this day and age and market.
Yeah, I agree. All right. Well, James Dismond, company is MiraSol Health. Thank you so much for being here. Congratulations on the big donations and the big fundraiser. It's great what you guys are doing. Really appreciate your time.
Thank you so much for having me. It's been a delight.